pulmonary venous anomalies. Can we have the lights down, please?
Charles J. Steve.
There are a couple of kinds of pulmonary venous anomalies. One is partially anomalous pulmonary venous connection, in which some but not all of the pulmonary veins connect either to the right atrium or to a systemic venous tributary, as opposed to connecting to the left atrium. So what we have is a situation something like this, where in this example the left upper pulmonary vein connects to the left innominate vein. And so there's mixing and increase of saturation around to the right atrium, right ventricle, and out the pulmonary arteries. So this results in a left to right shunt that's pre-tricuspid. It's not like a ventricular septal defect, it's more like an atrial septal defect. So it's a volume load for the right ventricle. That's the ventricle that's doing the extra volume work. There can be variable pulmonary hypertension depending on the exact setting. For example, in Scimitar Syndrome, that we'll talk about in a moment, we often see pulmonary hypertension. Whereas in isolated pulmonary venous connection, at least during childhood and adolescence and early adulthood, one almost never does. But we have seen a few middle-aged adults coming back in their 40s to 50s with an isolated venous connection anomaly with pulmonary hypertension and right heart failure. So it's possible to happen late even with an isolated connection. And then variable pulmonary vein obstruction. Sometimes the veins, even in partially anomalous pulmonary venous connection, can become obstructed, but it's pretty uncommon. So here's an example of this. Here we see the left lower pulmonary veins here from the left lung coming back to the left atrium. Here's the left pulmonary artery, and here's the left upper pulmonary vein here that doesn't drain to the left atrium, but instead drains up to the innominate vein. Here you can see the innominate vein with the left jugular vein coming in here, the right jugular vein, and the superior vena cava coming down here. So here's the cava coming into the right atrium. And you can see that the cava, the atrium, and the right ventricle are somewhat dilated in this patient. The coronary sinus here is normal, and here's the right ventricle and right ventricular outflow tract. So this is partially anomalous pulmonary venous connection of the left innominate vein. We've seen this with a sinus venosus defect, the right pulmonary veins draining anomalously to the right superior vena cava, so we won't continue with that. But let's talk about Scimitar Syndrome, which is a group of anomalies that go together and usually are associated with anomalous pulmonary venous connection of some or all of the right pulmonary veins to the inferior vena cava at or just below the right atrial junction. Usually there's right lung hypoplasia associated with this. Dextroposition of the heart, because the right lung is small and doesn't take up enough room in the chest, the heart tends to be moved over into the right chest. And there may be sequestration of usually right lower lobe segments of the right lung, one or more segments. Sequestration means that there's an anomalous arterial connection supplying that segment from the descending aorta, and little or no communication of the airway of that segment with the normal bronchus. So here's an example of scimitar. Here you can see the left lung, and this is all there is of the right lung. It's very hypoplastic and dysplastic, as a matter of fact, in this case. Here we see the aorta and the pulmonary artery. In the right atrium, as we open the right atrium, we see the inferior vena cava here, and this is the scimitar vein from the right lung here coming into the back of the cavo-atrial junction here below. You can see there's another little cord that comes across up here on the top from the upper part of the lung, but it didn't have a lumen in it. It's a fibrous cord. It perhaps was a pulmonary vein, but has become atretic throughout its course, which can happen in this as well. Here, as we open the left atrium to see the left atrial appendage up here, You can see the left pulmonary veins here coming back into the left atrium from the normal left lung on this side. So this is the right pulmonary veins draining below the diaphragm. Here's an example of this with a sequestration artery. Here we're turning the liver over. Here you can see an artery here that comes from the descending aorta and comes up to the base of the right lung. Here's the descending aorta right here, and this artery comes from it and comes up to the base of the right lung to supply the sequestered segment. We can often see these actually with color Doppler as they run sort of through the liver or by the liver, and you can certainly see them with magnetic resonance imaging. And it's an important point for the surgeons to know about exactly where the arterial supply comes from. Now, totally anomalous pulmonary venous connection means, of course, that all of the pulmonary veins connect anomalously to the right atrium or to one or more venous tributaries. And they can drain together all in one spot, or there can be multiple mixed drainage, or there can be actually multiple sites of drainage from a single collecting system. We've seen veins that form a single collector and then have drainage below the diaphragm as well as to the superior vena cava. The physiology in this case is common mixing in the right atrium generally. Systemic venous blood and pulmonary venous blood mix in the right atrium. There is flow across the interatrial septum. There has to be in this case. And flow through the pulmonary artery out into the lungs. Then the systemic blood flow has to go across the atrial septum, of course, to get into the left ventricle to get to the aorta. So one can see restriction of pulmonary venous flow either along the course of the vertical or connecting vein. It may pass between a bronchus and an artery, for example, and cause obstruction. It may be obstructed where it passes through the diaphragm. This is shown connecting directly with an hepatic vein. Usually it connects with the portal system. And when that happens, of course, then the pulmonary venous blood has to traverse the liver sinusoids. So it has to go through another capillary bed, and this virtually always causes some degree of obstruction whenever the pulmonary veins drain into the portal system. And then one can see individual pulmonary vein obstruction or hypoplasia, which is predictive of development of obstruction later on. So this again is a right ventricular volume overload lesion. The right ventricle is pumping the extra. There's variable cyanosis depending on whether there is obstruction and how much pulmonary blood flow there is. Obviously, the more red blood coming back into the mix, the higher the saturation. The less red blood coming back into the mix because of obstruction, then the lower the saturation. Variable pulmonary hypertension, again, depending on whether there's obstruction, particularly of the pulmonary veins. And variable pulmonary vein obstruction, as we've already talked about, along the course of the pulmonary venous channel. So here's an example of infracardiac veins. Here we see the aorta and pulmonary artery. Here's the right atrial appendage. We open the right ventricle. It's somewhat dilated. Here's the inferior vena cava here in the right atrium. Here you can see the superior vena cava, and there's a large patulous foramen ovale here, which is how blood gets into there you can see the hole, which is how blood gets into the left side of the heart. We turn this over, you see that the left ventricle is relatively small, as it sometimes is, or often is, in anomalous pulmonary venous connection. And here the left atrium just is blind. There are no pulmonary veins coming into the back, and there's the communication with the right atrium. Right there. Now, here we're already seeing the venous connector, but as we turn this over now and view everything from the back, this is now the patient's left, and this is the patient's right. Here you can see the trachea and bronchi up here, left and right lungs, and here's the pulmonary vein confluence and connector below the diaphragm. Here you see a left upper and a left lower vein coming into the side here, right upper and right lower coming in, and then the vertical vein going below the diaphragm here to join the, actually in this case it joins the portal sinus here in the liver. This is the inferior vena cava over here, and you can see that there is a communication here between the portal sinus directly into the inferior vena cava. So that's infradiaphragmatic type of veins, and as we said, obstruction can be within the liver substance, it can be along the course of the channel, or it can be in the individual pulmonary veins. This is another example of infracardiac with, here you see the pulmonary artery, which is quite small here. In this case, you can see the heart points to the right. This is a patient with dextrocardia with heterotaxy syndrome, who actually happens to have a sizable left ventricle in this case. There's pulmonary stenosis here, and the aorta is here further to the left. This is double outlet right ventricle. And as we look, here's the inferior vena cava coming up on this side. As we turn the heart and everything over, here again you see the venous collector with the right lower, the left veins, left upper veins coming in here, forming the confluence, and then the vertical connector coming here again below the diaphragm. We can also have connection to the coronary sinus. At the cardiac level, here's superior vena cava, aorta, and the pulmonary artery here with the right ventricle, a large right atrial appendage there. You can see the pectinate muscles. Here's tricuspid valve and the right ventricle. Here is the foramen ovale area here. And as we get out of the way here, we'll see that this is the coronary sinus, which is quite dilated here in the back, and that will receive all of the pulmonary veins. The pulmonary outflow tract here is unobstructed. You can see the outflow pulmonary valve here. The right ventricle is large, and it's all unobstructed. The left ventricle, again, is rather small in this case. You can see this. Here's the mitral valve, left atrium. And again, there's no pulmonary vein coming into the back of this left atrium. If we look now at the coronary sinus from below, we see the right lung over here, and the left lung we already pointed out, and my pointer's not working now. Coming into the coronary sinus, there's the left. We just tipped the heart up to see this, and this is the right pulmonary veins coming into the coronary sinus in the back of the heart, and then draining into the right atrium. So this is veins to the coronary sinus, and this is supracardiac. Excuse me. Here you can see a large innominate vein. There's the aorta and the pulmonary artery. You see the large innominate vein in front. Here's the right atrium, which is also dilated. The right ventricle is large, and this is the orifice of superior vena cava up there, which is also quite large. The right ventricle is dilated, but otherwise somewhat hypertrophied, but otherwise looks pretty normal. The left ventricle, again, in the back is small, but not generally too small to support the systemic circulation. Here you see a little left atrium with no veins, and the foramen ovale right there is the means of ingress of blood for the left side of the heart. This is now the right lung and the left lung. We've just tipped the heart up. So here's the right upper, and here's the right lower pulmonary veins coming into the horizontal confluence. Tends to be a little bit oblique as it runs across from right to left. Here's the left lower vein here entering, that one. And the left upper vein enters a little bit higher up right there. And then the vertical vein continues around superiorly to the left of the pulmonary trunk there to reach the innominate vein. As we tip the heart back down, you see the innominate vein here in front of the aorta coming to the superior vena cava, and there you see the left jugular, right jugular innominate vein coming into the superior vena cava, so that this is the pathway for the blood to travel. And I think we'll stop at that point.
I hope you all had a nice lunch and you're rested, especially in the mind, because we're going to assault you again. The other monitor seems not to be working. I guess doesn't matter. One screen's enough for all of us. This is the right talk. We're in the right room. Okay, so we're going to talk about anomalous pulmonary veins of all sorts, and I'm going to do things in absolutely the reverse order from Dr. Sanders. I'm going to start off talking about total anomalous pulmonary venous return, and then we'll talk a little bit about partial anomalous pulmonary venous return. So there are a variety of clinical presentations, particularly for this group, to know about the neonate with respiratory distress when the veins are obstructed, it can be indistinguishable from hyaline membrane disease in premature infants, and is frequently indistinguishable from persistent pulmonary hypertension of the newborn. And many of the patients that come to us that way get an echocardiogram, because in the alphabet echo comes before ECMO, and we don't do the ECMO until we've done the echo, because it's very embarrassing when you, and it's happened, when you put the patient on ECMO and then you get the echocardiogram and you find that the patient's really got total anomalous pulmonary venous return with obstruction. So I've said all of that, right? So the other thing about it is that it's an emergency cardiac presentation when there's obstruction. So the lesions I would like to talk about can be classified according to the site of drainage, and they call type 1, type 2, type 3, and we'll tell you about the other types in a minute. But type 1 is above the heart, which is the commonest. About 60% of all of total anomalous venous return is of the type that Dr. Sanders showed the last, which is the superior caval. It's also interesting that because of the variation of venous flow, some of those obstructed. And if you have obstructed veins, the likelihood is still that you're dealing with supracardiac veins rather than infracardiac veins. But infracardiac veins are always obstructed, no matter what. They can drain to the heart, and they drain to the heart in two different places. They usually drain, the most frequent one is to the coronary sinus, less frequently to the right atrium, and one that is frequently missed by ultrasonographers. And then, of course, they drain below the heart. There's a fourth type, and we call these mixed pulmonary venous drainage, because it actually behooves the echocardiographer to always look for another site of drainage. You should find 4 veins, and if you find 4, you should be looking for a 5th one, because that's the one that's going to confound you, and you don't want to leave a patient with a partial anomaly if you can help it. So I call these 5 different kinds of veins, where I separate veins to the coronary sinus from veins to the right atrium. And as you know, the venous drainage, the lung is part of the primitive foregut in its development, and it ascends from the coelomic cavity to its position in the chest. It takes its arterial and its venous supply with it, and sometimes it doesn't go correctly, so you may get remaining drains to the systemic venous drainage or to the portal or the hepatic system. And just like for ASDs, I like to start with general things. And here's a heart that's beating rather fast, a patient with tachycardia, and you can see firstly that the left atrium is very small, as is the left ventricle. The right heart dominates, and the shunt appears to be going right to left at atrial level because of the position of the atrial septum. The right heart is enlarged, the septum is pushed backwards, and the left ventricle may almost appear as if it's a hyperplastic left heart. So we look over here and you see again a small left ventricle with this telltale sign here. There's a line behind the back of the atrium which doesn't receive the pulmonary veins. And in fact, if you look sometimes, you can see above the pulmonary arteries, you see a venous structure running above the heart. And we look on a variety of planes, looking subcostally. Again, you see the enlarged right heart and the small left ventricle with the paradoxical motion of the septum. So you suspect an atrial or a venous shunt under those circumstances. Here's another caveat. Here's a patient who's got a suprasternal notch view, and you can see that the biggest structure in the mediastinum here is actually the innominate vein. When the innominate vein is bigger than the transverse aorta, you really have to worry that it's carrying a lot more blood than the transverse aorta. So watch out for anomalous venous drainage under those circumstances. Big innominate vein with a little rouleau formation in the vein because of slow flow. And here is a pathological example, just as Dr. Sanders had shown us. And the thing about the veins is their passage where they drain is really much more variable than the artery. So sometimes the veins drain in front of the bronchus, but sometimes they drain in front of the pulmonary artery. If it drains in front of the bronchus and behind the pulmonary artery, you get what they call the hemodynamic vice. And that is the vein is then sandwiched between the bronchus, which is stiff, and the pulmonary artery, which isn't. But as the obstruction occurs, they get reactive pulmonary hypertension, which makes the pulmonary artery harder. When the pulmonary artery gets harder, then you get obstruction. When the obstruction gets worse, then the cardiac output falls. When the cardiac output falls, then the obstruction gets less severe and they get better. So you get this kind of course where they look like they're getting better. You think you've done a maneuver, you've given the patient some bronchodilators and it's got better, and you attribute it to the bronchodilators and then it gets worse, and then you give it some other drug and it gets better, and you say, oh, well, my treatment keeps on helping on an intermittent basis. Really, the problem is total anomalous pulmonary venous return with an undulating course. So here you can see what you can see echocardiographically. This is taken from the suprasternal notch view. You see the aorta and the pulmonary artery, and you see the venous drainage here from the upper and lower right pulmonary veins, upper and lower left pulmonary veins, and then it scoots over the pulmonary artery and joins the innominate vein. It joins into the heart, just as we see on this pathological example, and these other pathological examples, this one taken from the subcostal view, both of them. So you can look at this from a variety of veins, and when you see the blood traveling away from the heart in a venous structure, it's usually a bad sign. So watch out for the direction of flow into the pulmonary veins. If there was flow from a left superior vena cava, it would be red here. It's blue. If there was blood from a left superior vena cava going to the coronary sinus, it would be blue here. So we have to watch out for the fact that the blood's traveling in the other direction. Now here's an example of the hemodynamic vice, and this is an example of supracardiac venous drainage with really almost an air bronchogram that you can see. The heart is small. Okay, when you look at the veins, you can see that they're draining vertically, and when you look at the Doppler color flow, you can see a change just behind the left pulmonary artery as the vein is squeezed between the bronchus posteriorly and the pulmonary artery anteriorly. And then you get this kind of a Doppler signal, which we'll see in greater detail. This is from an article I wrote, which is running at almost 2 meters per second constantly, and that's obviously running towards the neck, which is the wrong way at very high velocity. So here's the total snowman appearance as we've seen, and as we see here on this example. And when there's obstruction, as we see below here, you can see the acceleration of flow occurring at this point over here as the vessel crosses the pulmonary artery. And when you do a Doppler from here up towards the neck, you see low velocity flow, and then as it gets caught in at the vise, you see the jet coming towards you here. And that is different from what you see when there's no obstruction, when the signal goes towards the baseline at the end of an atrial contraction. So total veins, and here is the example of the hemodynamic vise. You see the veins running between the bronchus and the pulmonary artery over here, and it gives rise to this kind of signal. And with Doppler color flow, you can see exactly at the site of the left pulmonary artery where it's trapping the pulmonary venous confluence here, which you see beautifully with all the pulmonary veins draining in here because of the obstruction. You can see the acceleration beginning at that point and extending all the way around the anomalous vein. So really not a difficult vein to, not a difficult diagnosis to make, I don't think. But always work from the general, big right ventricle, small left ventricle, no veins draining to the left atrium. Now, this is a sort of an Italian pride thing of mine. This is the finding that was described by Dr. Bruno Marino, who wrote a paper showing 7 patients with total anomalous pulmonary venous return to the azygos vein. And of those, 3 of the 7 had right isomerism or asplenia. So I think when you see an azygos vein with all the veins draining to it with obstruction at that point, think that you're dealing with a heterotaxy type syndrome. And there you see again from the suprasternal, this is subcostal view, you see the obstruction occurring with the increased velocity entering the superior vena cava and the size of the superior vena cava increasing dramatically. Now here's veins draining to the right superior vena cava. We don't see them draining up on this side, and there is variability to the drainage even when they are in a partial anomalous venous return. It's draining to the left superior vena cava on this side, and you see the flow velocity in the superior vena cava is abnormal. And when we look subcostally again, you can see this tree of the pulmonary veins joining the confluence and not draining to the left side, but draining to the right side of the aorta and going into the superior vena cava. And then back into the right atrium with increased velocity. Veins directly to the right atrium are quite uncommon. Here you see a specimen dissected from Bob Anderson's collection, and you see all the veins here. Here's Waterston or Sondergaard's groove, and you see the veins are draining to the back of the right atrium. And that's an easy diagnosis to make usually. Here you see the pulmonary veins scooting over the back of the left atrium here and draining into the right atrium. So once you see veins from the left side draining into the right atrium, it's not very difficult to go and trace the veins from the right atrium, right side draining into the right atrium. Here's that same example, the same disease again, with the veins draining over the back of the atrium. And here you see in the still frame before I begin the movie, the right upper pulmonary veins draining to the left atrium and the left pulmonary veins draining to the right atrium. I said left atrium, I meant right atrium. And here is such a picture with color flow showing all of the color flow, and this was proven to be very valuable. There's one thing that I'll give you as a tip if you're going to do this, and I think Girish mentioned it, but he's not here at the moment, is when you look for veins, because the velocity of flow is low in the veins, you want to lower the scale on the Nyquist limit. And many of the new machines like the I-33, which is a wonderful machine, defaults into the highest velocity settings. And if you do that and you don't lower the scale for the Nyquist limit, by lowering the velocity section, you'll miss veins. You'll miss a lot of structures that have low velocity. And when you're looking for something like this, if you have suspicion, you must lower the Nyquist limit, the scale. Instead of having it run at 100 centimeters per second in either direction, get it down to 20 or 15 centimeters per second, and you'll find all the veins. Here's veins draining to the back of the right atrium, directly to the back of the right atrium. And you see in the subcostal sagittal view, the inferior vena cava, superior vena cava here, and the veins from the right atrium all draining into the back in that view. And we've seen these other views below. You can see it from the short axis and subcostal views. It's not a difficult diagnosis. Now, veins to the coronary sinus, often called the whale tail appearance, because the veins drain into a dilated coronary sinus, and of course you can do that. And then you can buy this package for software which shows everything over here. So you see the whale tail, then you see the color flow, and then you get the picture. So you can watch that, and I think that tells you very clearly the kind of venous anatomy you're seeing. There's another whale's tail sign for you, but, and then I think this is the big but. In looking for coronary, for veins, you always have to look for this, and this is a patient where you say, aha, total veins to the coronary sinus. But if you look above here, you can see that this patient also has a partial anomalous drainage, or an anomalous venous drainage to an upper structure, to the vertical vein on this side. So we call this a type 4 or mixed pulmonary venous anomaly drainage. And I wanted to look at these because I think that what you see with this kind of venous drainage is exactly what you see with a spectrum of partial anomalous pulmonary venous return. So I think in making instruction on this, it's easier to do it this way. Now, these are veins below the diaphragm. This comes from a patient with right atrial isomerism. You can see the pectinate muscles on both sides, and the so-called inverted Christmas tree look. Here's another one just like Dr. Sanders had shown us that goes to the back of actually the left side, which is kind of important. And this is a view that was actually popularized by my friend Jeffrey Smallhorn, where he looked from the suprasternal notch in the coronal plane and pointed the probe down to the back of the heart where the veins lie behind the back of the heart, and show you all of the pulmonary veins draining below the diaphragm. If you can't see them, I'll put it in motion and I'll add color. And once you add color at a low velocity, 28 centimeters per second, you see all the veins draining, the upper veins, the lower veins, the upper veins, the lower veins, and they drain into a confluence, or sort of vertical confluence. And at this point here is where the diaphragm sits. So you can see them draining actually to the point where they perforate the diaphragm. So this is an important view, valuable view, and easy to do. And of course, all of these patients are small and very sick. So ultrasound is the primary means of doing this diagnosis. When you get a vertical vein going below the diaphragm, it usually drains through the esophageal hiatus, okay? And there may be obstruction at many levels. There's no obstruction to this vertical vein at this point in time. If you look at it in the sagittal plane, you can see the vein draining, and that there's an obstruction here at the porta hepatis where it joins the portal vein. Huh? And let me look at another one for you. This is, I think, is the classical diagnosis. Here is the pulsatile descending aorta, and in front of the pulsatile descending aorta is a venous signal which is traveling away from the heart, which is actually the descending vertical vein draining towards the porta hepatis. And when you look at this in other sections, you see the vein draining into the porta hepatis, and then you can actually see obstruction between the vertical vein and where it joins the left hepatic vein and drains into the diaphragm. Here's another one here. You see the vein going across here, and then you see it entering this hepatic vein before it enters the inferior vena cava. And of course, the velocity is high and obstructed in all of those. And of course, we call it total veins, but another surprise, this patient also had mixed total veins with one of the veins draining above. Now, there's a number of things that are important about this. Number one, if you leave a partial anomalous pulmonary venous return, as Dr. Sanders had mentioned, this is a kind of a patient who, over the course of life, because the vascular resistance between the pulmonary venous and the systemic venous circulation is low, is likely to get an increasing amount of blood flow to that vein. So as they grow older in life, it gets more significant. It's also quite easy to anastomose this vein to the atrial appendage. So with little extra effort, you can actually fix all of the veins. And here's another example showing the same features. So not all total veins always drain the same way, and it behooves you to look at them. And this is what happens when you have partial veins. This is actually a very interesting patient. The patient had an ASD repair through a lower sternotomy. And because she was a young lady and nobody wanted to give her a big thoracic scar, so she couldn't wear a bikini, they operated through a lower thoracic incision, and she was found to have a partial vein which was not recognized. And this is the echocardiogram that we got from her. Okay, and so there's the left vertical vein. I mean, it looks just the same. Here, the rest of the veins draining to the back of the left atrium. So a solitary vein. And now the Scimitar Syndrome. Here's the old scimitar. What we're looking at here is the heart has been reflected to the left side, because what keeps the heart actually in the chest are really basically the pulmonary veins. So when the pulmonary veins are not attached to the back of the left atrium, the heart is excessively mobile, which is good for the surgeons because they can repair it. But here is the left bronchus, the right bronchus, and here are all these veins. This was a diagnosis made by Catherine Neal, who said it was a scimitar. This is not a spleen, it's the lobulations of a neonatal kidney. And of course, there's my example of what a scimitar really looks like. And you can see I didn't get an A for art when I was at school. Now, as Dr. Sanders mentioned again, and I hate to keep on repeating what he says, but they say one thing about education: if you repeat what you say, people tend to learn. But these patients have hyperplastic right lung. And the commonest cause that we find for a dextrocardia or dextroposition or mesocardia is the hyperplastic left lung associated with Scimitar syndrome. So when you see the apex of the heart underneath the xiphoid process, that means the heart's apex is shifted to the right side. And so the caveat under that circumstance is look for a Scimitar syndrome. And Dr. Hasbani has got some brilliant pictures of the Scimitar syndrome. Here's an angiogram. There was an angiogram. Here we go. And there's an angiogram, and you see where the scimitar drains. It usually drains above the diaphragm, doesn't perforate the diaphragm, but drains into the IVC. If it does drain into through the heart, it usually comes through the IVC hiatus and not through the esophageal hiatus. But it's most likely to a supracardiac form of drainage. So here you can see when you put the color flow on, and again I'll show you we're using 23 to 39 hertz in this series of pictures. Here's the vein. It's draining above the diaphragm and into the supracardiac portion of the inferior vena cava before it enters the right atrium. Sometimes there's obstruction there. Now if we look at it on the lateral basis, let's just look at this picture. Here's the inferior vena cava, and here's the right atrium. Normally the right upper pulmonary veins run on the top of the diaphragm and head south in this direction. But this patient has a scimitar, so it's no surprise that you can see the blood coming down towards the IVC, and then you see this turbulent flow related to the jet of this high velocity flow getting into the pulmonary veins, which you can see from a long axis. There. And you can also see from a subcostal sagittal plane. And here runs this lower vein. Instead of running up this way, it runs down and into the inferior vena cava. So that's about, I think, all I've got to say about veins. No, there's still more. Here are veins that are draining partially anomalously to the superior vena cava, just separately. And there you see the vein draining into the back of the superior vena cava, scooting over the right pulmonary artery and bronchus in this stage, and entering much as an azygos would, but this was not an azygos vein. As you can see, there's an anomaly because the right upper pulmonary veins are not draining there. And here, once again, if you look subcostally, you can see the anomalous vein, and you can follow its course without color, and then you see its course with color draining into the right atrium. The right upper pulmonary vein is not seen in the left atrium at all. And as we see here, even with this velocity of 61, you can see the superior cava, and you see this vein draining into the back of the atrium there as well. And at 90 degrees in the other plane, you can see the flow coming across into the upper part of the right atrium, and the Doppler signal, which returns to baseline, indicates that there's no obstruction in that vein. So thank you very much. All right, now you're going to see something really remarkable.
All right, so anomalies of the pulmonary venous connection, and I think I mentioned to you guys initially that one of the things that MRI is best at is the cardiac structures that are really outside of the heart, instead of the intracardiac, the extracardiac, the systemic venous return, IVC, SVC, the pulmonary venous return, and then the pulmonary arteries and the aorta. So we're going to talk about that a little bit with the pulmonary veins. We know pulmonary veins abnormalities are relatively rare, but they're really challenging for a couple of reasons in the treatment of children. The biggest one is really keeping them patent after you've improved them. So if you find anomalous, total anomalous pulmonary venous return, partial anomalous venous return, and any of these things, the problem is after the surgeon goes in and fixes them, they tend to close back up or become stenotic, even in the region where they're touched. And so there's really three things that you're going to look at. You're going to try and visualize the veins, where they connect, and then you're going to try and find the anatomical details that you're going to do so that you can figure out the functional detail from that. In other words, how much blood is actually going through each vein, and then hopefully do that in a non-invasive, without radiation procedure. And the techniques that we're going to use are very similar to the ones I've shown you. You're going to use the cine imaging that we've seen time and time again. You're going to look at the MRA with the gadolinium. And last, you're going to look at the velocity encoded. And I'm really going to start with the velocity encoded first. So up here you can see, is the pointer? Oh, okay. So you can see the aorta, right atrium, SVC, and then the right pulmonary artery and the pulmonary vein. And so you're going to draw your circle around the pulmonary vein, and you're going to get a flow across that. And what that's going to show you is you've got your magnitude, your velocity, and then the time velocity curves. And in the time velocity curves, you're going to see your movement across the pulmonary vein, very similar to what you would see in Doppler if you Dopplered the pulmonary vein and you saw your movement of the blood flow across that. Next to it, you see the pulmonary artery with the forward and a little bit of the diastolic reversal sort of at the end. And why is that important? The reason that's important is you're going to look at things like scimitar, and you're going to be able to look to see what the pulmonary veins, I'm sorry, this is not scimitar, this is, I apologize, this is pulmonary veins. And what you're looking at is you see the 4 pulmonary veins coming in, but you can especially see that the left pulmonary vein, the upper, is quite small, and so is the lower, not as small. And this is initially before surgery. You can see that they're abnormal, and then after surgery, they're even more abnormal, and they've become stenotic even though the patient was repaired. This is right after birth, and this is 8 months later. This is a scimitar, and you can see the scimitar. I don't know if it's going to play for you. Here's the scimitar vein connecting to the IVC. Again, here's the scimitar vein, and you can see the abnormality, you can see the pulmonary artery, and then the pulmonary veins connecting to it. And one of the things that's really nice is you can also color code where the blood is actually coming from. And so you can look at it and see the color code of the blood specifically. And so if I play that for you guys, you can see the location of the blood. And the blue is the deoxygenated blood. The red is the oxygenated pulmonary venous blood that's returning to the IVC. And then the purple is sort of where it's mixing together abnormally. And so that's a very nice way to sort of look at your pulmonary venous return, see how there's an abnormality in the right atrium of the flow. You can see almost like a swirling effect that happens in the right atrium. And then you can color code also where the different venous drainage occurs, the yellow being the portal. Again, in scimitar, you can see the right atrial. This is the same image that you saw before, but it's slow motion. You can see the flow and how it actually swirls in the right atrium rather than having normal laminar flow. This is a patient that has congenital stenosis of the left pulmonary veins. Here, the left lower pulmonary vein is quite small. The left upper is actually pretty good size. What you can see that's happened is most of the blood flow is going to the right pulmonary artery rather than the left pulmonary artery. You can see that also by flow. And you can see 73% of the blood is going to the to the right lung, and only 27% is going to the left lung. You can see the left pulmonary artery is small, probably just from blood flow, but not abnormal. And so the pulmonary artery should have been able to grow just fine if you increase the blood flow. However, after the patient was repaired, it's still abnormal, and now you can see the left pulmonary artery is even smaller compared to the right pulmonary artery. There's even less blood going to the left side, and now when you look at the left pulmonary artery, it's actually got a reversal of flow during diastole, and so almost 99% of the blood flow is now going to the right lung instead of the left. And now you can look at the pulmonary venous return, and you can see very little pulmonary venous return to the lung. And so you know that you've got restenosis of that pulmonary vein. And eventually what's going to happen with this child is that left lung is also going to stop working appropriately because there's very little blood flow in it. So partial anomalous pulmonary venous return, we've seen a couple of these images. Here's the pulmonary vein returning across into the innominate, connecting with the SVC. Here it is again. Here's your aorta coming out. Here's the partial pulmonary vein returning to the innominate and then down to the SVC. Here it is one more time. Now you see the tree very well coming back into the innominate and connecting to the SVC. A total anomalous to the IVC, excuse me. And you can see the pulmonary veins connecting down to the IVC down below. Again, same thing. Just stop. But you can see same thing on the other side with the pulmonary veins connecting. So CMR for pulmonary veins, just quick conclusion, you can get a QP-QS ratio, but more specifically you can get QP to the lungs. Each lung specifically to help you differentiate how much blood flow is going to the lung. You should also get how much blood is going to the pulmonary veins specifically. You get the anatomy of the pulmonary veins, and then you can follow these patients up regularly for pulmonary vein stenosis, which many of them get after they get surgical repair. All right. Questions? Any questions from anyone? No?
Can I make one general comment as a neonatologist? I know that I think there are a lot of things very complicated and complex for us to catch up with, especially when you are seeing the supracardiac images. Sometimes it looks like the PTA is going towards the heart. The second thing is many times we are asked to give, when a little baby, term baby, responding without ventilation, stuff like and all those things. So my other colleague asked us to, can we just see that is there any or not. But as a pediatrician, I think that's one of the very difficult diagnoses for us to make. But one thing I take it as a clue, if there is a pure left to right shunt to the foramen ovally, then I can say that there is no total anomalous pulmonary venous drainage. Is it right or wrong?
I think it's reasonable. In fact, one of the
For
things
total,
that I've
yeah.
employed as a technique is to do a little saline bubble injection.
Yes.
And if you don't see a right to left shunt at atrial level, you don't have pulmonary hypertension and you don't have pulmonary veins. So that takes care of those two diagnoses right off the bat. Unfortunately, if you've got total veins, you will have a right to left shunt, and if you've got any degree of pulmonary hypertension, you will have a right to left shunt.
It has to be right to left shunt.
Yeah, but I don't think that actually looking for veins is that hard if you follow the guidelines that I put to you for doing this. I think that you should use color liberally, and I think that you have to lower the Nyquist limit because the flow of velocity in the veins in normal circumstances is in the 10 to 20 centimeters per second velocity range. So if you've got 100 millimeters of velocity, then what you're looking at is in the dark red, dark blue, black range. Okay, so you'll miss it. So you have to lower the Nyquist limit, that scale, down to about 20 to 28 up. We've pointed out a few of them over here. And when you do that, you start to actually see what's going on. The other thing that you have to do is, I think, mentioning the color to you. Do you have color in your system?
Yes.
Because if you don't have color, I can't talk to you. But if you have color, the other thing you could do, and we talked about this earlier on, is you can make the sector smaller. If you have a magnet guide with a zoom view, and you're just looking at that small section, and you lower the size of the color box, you get a much higher frame rate. So you get a much more real appreciation of what's going on. So those are a couple of things that I would look for, and I would encourage you to use the views that I've used to look for this in the neonatal period. I think you can see also with just a simple subcostal view in a baby that comes in for ECMO, if you just need 10-20 seconds, if you see the veins draining to the back of the left atrium, you are not dealing with total anomalous pulmonary venous return. It's when you don't see them that you've got a problem. So I think those are a couple of quick screening tests that will help you take the dilemma out of making these diagnoses.
I think the view that I tend to like to use in echo is what we call the crab view, where you're going up in the suprasternal notch. I know the subcostal view is very good, but frequently some of these patients are now hyperventilated by the time they come to you because somebody is trying to fix them, get them better. They're hyperventilated. Your subcostal views sometimes are not coming out as well because they're ventilating so fast and so hard. You're not able to get a good subcostal view. And then if you go up here to the neck area, get them hyperextended or a nurse to hold their neck up, and you look at the subcostal, you look for the suprasternal notch, and you're looking for the pulmonary arteries. The color, if you turn it down low enough, is going to be your friend in telling you which direction those veins are going. Because you're going to see an SVC, you may see a left SVC, but if it's flowing the wrong direction, then you know that you've got a vertical vein or a horizontal vein that's connecting to the innominate. And so that's where I think, and that's the same thing that I was telling you guys about the velocity encoded images for MRI. If you pick too high of a level, everything becomes gray on my scale. If you pick too high of a level for color Doppler, same thing happens. You get no color differentiation. If you're trying to see the veins, all of your other things should be super fast and aliasing everywhere. So if you're turning down the Nyquist limit low enough to see the veins, the pulmonary artery, the aorta, all of that are going to be very fast and are going way faster than you're going to be able to see. So all of them are going to be Nyquisting. And you want to see that. If you're not seeing Nyquist aliasing in the aorta and Nyquist aliasing in the pulmonary artery, you've not lowered your Nyquist limit enough. Do you agree?
But I wouldn't agree with you about going to the crab view. And the reason I wouldn't agree with you is, to my mind, when you hyperventilate a baby, the lungs cross over, especially in the upper mediastinum, and it's very hard to get there. Whereas from the subcostal or the what do you call it, subside point of view, if you come down there, you're actually imaging through the central tendon of the diaphragm, where there is no lung. And you echo through the heart, and I think you can see the veins better that way. So my first preference would be to be subcostal to look for veins. If I had one shot at looking for them, and often, you know, they're standing, the surgeons standing there with the knife waiting. You know, hurry up. You know, I want to know, do I cut or don't I cut? Because I've got other things to do with my life. Okay? So you just say, go ahead.
Yeah, I think it's important to recognize, you know, from the suprasternal notch, from the crash, you see 4 veins coming back. All that tells you is that there are 4 pulmonary veins. It doesn't tell you that they're coming back to the left atrium. You need other views to tell you whether they're coming back to the coronary sinus, below the diaphragm, or above the diaphragm, and those views are primarily subcostal views.
And my question is we able to, in that kind of malformation, show the separate single chamber near the left atrium, the confluence of the pulmonary vein is available, and it is some necessary to show or to know that that will be this malformation?
I don't understand that.
Because in that kind of disease, you can see the separate single chamber from the left ventricle, and is that necessary to say that this kind of malformation?
Yeah, I think so.
Curious, just before you
Because
answer the
sometimes
question,
the fourth chamber.
pressing the question so that everybody else can understand what he's asking.
Yeah, so I think the question, so correct me if I'm wrong, I think the question is, do you have to see,
Yes, why I
do you have to see confluence in the back to be able to diagnose total anomalous pulmonary veins? I think it's a very difficult question to answer, because you can have conditions such as pulmonary vein atresia. Now those are babies who don't survive for more than a few minutes. Really. They don't do well. They have really atretic pulmonary veins. So by and large, even if you have mixed veins, which is complicated, so you could have one vein that goes here, one vein that comes there, you should still have something behind the left atrium. That's usually the way it works.
And sometimes I can dismiss this aorta because in four chamber view it can goes like that, like aorta.
Yeah, so that's why you need the subs, because you know, because in the subcostal view, it's easy to differentiate the aorta from this structure that is in front of it. The other thing to kind of keep in mind with the whole echo thing is, even veins that go to the coronary sinus and supracardiac can obstruct.
So is it critical criteria to diagnose this malformation or not? Yes.
I'm sorry, what was it?
She's asking if you have to see the confluence, like the confluence, in order to be able to diagnose it. And I don't think we have to.
No.
I think it depends on what else is going on, you know. I mean, by and large, so if you see a vertical vein going somewhere.
So if I had some problems with the vein, I have to suspect that it could be.
Yeah. Sometimes confluences are small. You know,
Especially subcostal, the intradiaphragmatic, frequently there is no confluence,
there's no
it's
true
drain
confluence, because
without a confluence.
it's like a tree. So there may be a vertical vein with veins coming into it at different levels. So, and those are actually a challenge for the surgeon as well. So to me, that's still a confluence because it's behind the atrium. So it's a question of how you define things.
Thank you very much.
Just one last point. I think that the total veins is an emergency diagnosis, and it's a diagnosis that really there is no substitute for ultrasound. So I think that it's something that you really have to pay a lot of attention to and be very careful with, because you take a patient like that to the catheterization laboratory and you fill them up with contrast, and then you have a very sick patient that's got to go to surgery. So I think unless you really absolutely have to do it because you can't find the diagnosis, you should be able to make the diagnosis with ultrasound.
I think it's one of the last ones where we say that sun shall not set on the patient, you know, emergency-wise surgery. Now that we have prostaglandins available almost everywhere in the world, most lesions you give prostaglandins, you reopen the patent ductus arteriosus, you do not need to take them to surgery that day. I would say for total anomalous, you know, venous return, especially the infracardiac, but the other ones, really the surgeons will take that patient to the operating room within 24 hours of diagnosis. I think everywhere. Would you guys not agree?
Agree.
Yeah, it depends on whether they are
Yeah.
obstructed or not, but yes, in general.
In general, certainly infradiaphragmatic.
Yeah.
I think the others sometimes not, but because they're not always obstructed. Other questions or? All right. Shall we press on with this, or
Yes.
you need to stand up and jump up and down a time or two, or something like that? No? Okay. So this next session that Dr. Silverman devised is sort of a symposium on transposition and double outlet ventricle. These are clearly not the same thing. They may or may not share embryological mechanisms. It's a little unclear for a lot of these things what exactly the embryological mechanism is. There's some evidence in animal models that rotation of the muscle under the developing outflow is very important for aligning the great arteries correctly with the ventricles. There are actually different proteins that are expressed under the two great arteries, developing great arteries under the aorta and the pulmonary arteries, so that you can literally track the movement of the muscle and the great arteries during embryogenesis and see this. And certainly things like truncus and transposition are associated with an abnormal amount of rotation, usually less rotation than normal. So that may be one mechanism in common. For transposition, it certainly looks like at least left-right asymmetry patterning is important for development of transposition. Bruno Marino, who Norman mentioned earlier, has pointed this out several times, that there are genes that are involved in left-right asymmetry patterning that seem to be important also for transposition of the great arteries. So what do we mean? What do I mean by transposition? I mean a condition in which both great arteries arise on the opposite side of the interventricular septum from normal. They're placed across the septum, transplanary, they're placed across. So the aorta usually arises from the left ventricular side in normally related great arteries. In transposition, it's the pulmonary artery that arises from the left ventricular side and the aorta from the right ventricular side. In common transposition, which is what we're talking about right now, the ventricles are in normal situs, usual situs, or D-looped, right-handed ventricles, and there's AV concordance, the atria are in situs solipus, and the same as the ventricles. This accounts for, roughly 6% of congenital heart defects, 6–8%, something like that. And this is an example of this kind of transposition. Here we see, as we, that not start. What's going on here? Something bizarre is going on. I just looked at this over lunch. There we go. Fine. Anyway, this is an example of regular common transposition. Here we see the aorta, which is anterior and rightward, and back here the pulmonary artery, which is posterior and leftward. This is the pulmonary artery. Notice what else we see here. This is an unusual finding, but it happens in some cases of transposition. This is the left atrial appendage, and this is the right atrial appendage, but they're both on the same side of the great arteries. This is called juxtaposition of the atrial appendages. It happens in a significant number of patients with transposition. If we flip the great arteries down here, so that we're now looking at the back of at the atria. This is the right atrium coming across to form the right atrial appendage. And here's the left atrium, here's the superior vena cava. So this is an extension of the right atrium that comes across behind the great arteries to reach the left side. And both appendages are over here together. There's the left atrium here in the back. There's almost always a sizable atrial septal defect. There you can see it associated with juxtaposition of the atrial appendages. And this is the left atrium. There's the left-sided atrial appendage and down into the mitral valve from here. Now if we look inside, here's the right ventricle here. Notice this is the anterior descending artery here. It's much further to the right than usual. Usually the anterior descending is over here sort of on the horizon. And that's because the right ventricle is small in this patient. And juxtaposed appendages are a marker for small right ventricle. Here you can see this comes down. This is about the apex of the right ventricle, whereas the apex of the heart is over here. So here's the right ventricle, which is rather small. The tricuspid valve here, rather small. The septum is intact in this patient. There's no ventricular septal defect here. And this is the outflow up to the aorta. This is conal muscle or infundibular muscle. This is the infundibular septum here, this part. This is the parietal band coming out to the free wall. And there's the aorta separated from the tricuspid valve by conal or infundibular muscle. On the left side, we see the papillary muscles of the left ventricle. Here's the anterior mitral leaflet, the smooth basal portion of the septum, and the finely trabeculated apical portion. And in this case, we see that the mitral valve here is in continuity with the pulmonary valve. These are pulmonary valve leaflets. There's fibrous continuity between them. And here we see the pulmonary artery in the back with the two branches, left and right pulmonary arteries coming from it, the right there, the left here. So this is transposition with intact septum that happens to have juxtaposed appendages. This is an example of transposition with a ventricular septal defect. It's playing a little better. There's the aorta, there's the pulmonary artery. To the left, the aorta anterior to the right. In this case, there is just a patent foramen ovale. You can see septum primum there and septum secundum, coronary sinus, ostium. And then if we look in the right ventricle here, we see there's a ventricular septal defect here, and this is the inferior ramus of septal band with papillary muscle of the conus there. The superior ramus of septal band goes in that direction. And here's the infundibular or conal septum here. And you can see that it doesn't make it down to the Y of septal band. This is a conoventricular defect. There are the pulmonary valve leaflets, the aortic valve leaflets above, separated from the tricuspid valve by the infundibular muscle here. From the left side, we see the ventricular septal defect, the smooth and trabeculated portions of the left ventricular septal surface, the posteromedial and anterolateral papillary muscles, and you can see the anterior leaflet of the mitral valve here. And again, there's pulmonary valve here to mitral continuity. So this is, again, typical for transposition of the great arteries. And here we see, in this case, that this patient has a single right coronary artery. We've just reflected the aorta toward us. We're looking toward the back of the aorta now. Here's one artery right there that arises and passes around in the right AV groove. It also gives rise to the sinus, well, there's the left coronary coming around to the left by the left atrial appendage. And there's the sinus node artery, which arises from the single right coronary artery. If we follow the left coronary around, you see here's the left vein as it passes behind the pulmonary trunk and comes around, gives rise to the circumflex there and the anterior descending coronary there, which passes down the anterior interventricular groove. Now, there's another group of patients with transposition who have ventricular septal defect and pulmonary stenosis. Here we see a big aorta anterior and rightward. There's a very small pulmonary artery back here posterior, right there. So this is one of the relatively common variants. Here's the foramen ovale, which is small. Here we see again a conoventricular defect. There's the Y of septal band. Here's the papillary muscle of the conus, indicating the inferior ramus here, and the superior ramus there, with the defect in the Y. There's the body of septal band moving down the septum. And here you see the aortic valve leaflets are actually quite close to the ventricular septal defect in this patient. There you can see the 3 leaflets of the aortic valve. Now, if we turn to the left side, we'll see, no, we're looking at the coronaries. There's the right coronary arising from that sinus, and the left coronary right there from the left posterior sinus. Now, if we turn to the left side, you see the septal surface here. We see the ventricular septal defect there. And in this case, here are the papillary muscles, the anterolateral, posteromedial. And in this case, you can see here's again a very thin, fibrous infundibular septum below the pulmonary valve. This is posterior malalignment of the ventricular, the infundibular septum, causing subpulmonary stenosis. This is a prevalent type of subpulmonary stenosis that we see in patients with transposition. So these are dysplastic pulmonary valve leaflets here. There you can see a thickened leaflet. And this is the infundibular septum causing subpulmonary stenosis. There are other unusual forms of transposition that one can see. For example, this is a patient with transposition in which there's bilateral conus. Here's a small anterior right-sided aorta and a larger pulmonary artery. They're about side by side in this case. Looking in the right side, we can see a ventricular septal defect here. Here's the septal leaflet of the tricuspid valve. And in this case, you can see there's conal muscle here between the aorta, which is rather small, and the tricuspid valve. The aorta has significant obstruction by the muscle bundles here in the outflow tract below it. Notice all of this thick muscle, when you put that back together, causes subaortic obstruction. Here I think you can see how you put these back together. And there is a coronary ostium back there, which is the right coronary ostium in this case. And there's the left in the front there. In this example, we'll see when we turn to the left ventricle that here we see the papillary muscles, the anterior mitral leaflet, the septal surface. There's the posteromedial anterolateral. Here's the mitral valve, but notice that there's the ventricular septal defect, that the mitral valve is separated from the pulmonary valve here. Look, there's the pulmonary valve way up, and here's a lot of infundibular muscle between the mitral valve and the pulmonary valve. So this is a patient who has a large left-sided conoventricular flange or left-sided infundibulum that persists in some patients with transposition of the great arteries. This is an interesting example of a patient with a posterior aorta and transposition, just to illustrate that the location of the aorta is not what determines whether a patient has transposition or not. It isn't whether the aorta is anterior or posterior that determines this. This is a patient who clearly has a posterior aorta. As we look at this, here's the aorta, posterior and to the right. The PA is up here, anterior and to the left. Looks like normally related great arteries from the outside. But when we look at this from the inside, we see that in fact, here's aortic valve leaflets up here. There's a very tiny bit of muscle here between the aorta and the tricuspid valve. You can see there's a tiny bit of infundibular muscle there. This is the Y of septal band over here. That's the papillary muscle of the conus and the superior ramus and the rest of septal band here. You can see the very thin bit of infundibulum between the tricuspid valve and the aorta, and then the parietal band as it comes out to the free wall right there. So here the aorta is aligned with the right ventricle, but there's no subaortic conus. Here's the left ventricle, papillary muscles, anterior mitral leaflet here, and again, look, here's the pulmonary valve, also in fibrous continuity with the mitral valve. So both, there's no significant amount of infundibular muscle beneath either great artery. And there's the ventricular septal defect there. Now, in many cases, the mitral valve can actually achieve continuity with the aorta through the ventricular septal defect in patients with a posterior aorta, as you can see here. So this is an unusual type of transposition, but it's one that it's important to know about. This patient actually happens to have a long segment coarctation of the aorta here. This is the PA and the ductus supplying the descending aorta. Do you want to look at coronary anatomy, or do you want to do that by echo, Norman?
I'm actually going to defer the coronary anatomy to the section on congenital coronary anomalies. So
Oh, okay.
if you could just sit this there, otherwise we're going to run out of the time for today's session, I think.
We'll stop on this.
If you've got double hour, bit on here as well.
Yeah.
Afterwards.
Yeah, but I thought you wanted to do transposition, and then we'd come back and do double outlet.
Yeah.
So, as far as the ultrasound of the transposition, we have to define obviously the ventricular arterial connection, define the type and extent of the atrial connections, perform balloon septostomy when necessary. And there's certainly a lot of evidence to suggest today that if you don't have to do it, it doesn't do so bad for the brain. Define the presence of additional defects, define the coronary artery patterns, and we're going to defer the definition today until congenital coronary anomalies, which is, I think, the last talk of our conference before the presentation by members of the audience. So I've always used ultrasound as a guide for what I'm looking for pathology as my guide to ultrasound. Here's a patient with transposition. The aorta is arising from the right ventricle, the pulmonary artery from the left ventricle. There's the ductus. If we make the slice posteriorly, we get through the bifurcating pulmonary artery. We see the descending aorta and the ductus left to right shunt, and the pulmonary artery coming from the left ventricle. If we tilt the probe slightly so that we can slice through both great vessels, and obviously the tilt depends on the position of the great vessels and nothing else. Here you see both the slice passing through both aorta and the pulmonary artery. So the aorta is arising from the right ventricle. The pulmonary artery is arising exclusively from the left ventricle. There's no ventricular septal defect. Here's the left pulmonary artery. The arch is going in this direction, and here's the Ductus Arteriosus. And of course we can go again through the back of the left ventricle, and we see the pulmonary arteries, the aorta, and the Ductus Arteriosus in any of these subcostal cuts. In addition to looking at just the position of the great vessels, we also want to assess additional information like the presence of ventricular septal defects. As we see here, whoops, that all went all on one. Subaortic stenosis, subpulmonary stenosis related to a posterior malalignment of the ventricular septum. Here you can see the heaping up of this structure without a VSD. We can also define the position of the ventricles. Here's a patient who has dextrocardia, for example. Parasternal long axis, the difference between the normal heart and the transposed heart is that the outflow tracts of a normal heart cross each other at approximately 70 to 80 degrees. In transposition, of course, there's no need for a spiraling, or the spiraling doesn't occur embryologically. So left ventricle connects to pulmonary artery, right ventricle connects to aorta, as we see here. By the way, Steve, this patient that I'm showing here is one with juxtaposition of the atrial appendages, and the very largest membranous septum I've ever seen. So this is a long axis view passing through the left ventricle, smooth upper border, fine apical trabeculations, mitral pulmonary continuity here, as we see here. And the aorta is coming on the other side from the ventricle here. Now, if we scan a little bit cranially, we'll get to the area of the aorta and the pulmonary artery, and we can normally see that very interestingly. For the reason of the spiraling of the vessels, the ductus arteriosus lies in a quite prominent position. It's easy to see more in transposition than in any other condition. We see a innominate vein, innominate artery, left carotid, left subclavian, all in one go. And we see the pulmonary artery with the left pulmonary artery origin over here. And you see the direction of blood flow. In the short axis view, very important, we get to look at the coronary arteries. You can see the left coronary cusp, the right coronary cusp, and the non-coronary cusp of the aorta. This is called sinus 1 and this sinus 2. There's the left coronary artery here. We see that the commissures of the coronary the aortic and pulmonary valvular leaflets are usually well lined up, one with the other. Here's a very nice left coronary artery, thymus in the front. So this is, as you can see from the scale, is a small newborn infant. And we can see very beautifully the connection into the pulmonary arteries, which lie to the left and posterior to the aortic root. Vessels may still be in a side-by-side position, whether there is a ventricular septal defect or not. You see there the position when they're side-by-side, and the orthogonal position, although this is still detransposition. But I think in addition to showing a disparity of size here, you can see very nicely the origin of the right coronary artery. So we will look at that with ultrasound all the time. Okay, we've done that, so I'll move on. We look at various views. This is the apical four-chamber view, and you can see on this patient it's really not necessary to do a Rashkin procedure because there's an excellent atrial shunt, but there's also a little tricuspid regurgitation. Here we've identified posterior deviation of the outlet septum, as you see here in black and white in color. We see the size of the VSD here as a massive ventricular septal defect. This patient has got an isolated cleft of the mitral valve with caudal attachment of the crest of the mitral valve to the crest of the septum. And obviously, today I think the state of the art dictates that you do a Rashkin under ultrasound control. My colleagues where I work at Stanford like to do this in the cath lab or at the bedside, usually at the bedside, but they'll do it to the femoral vessels. When I was doing this, I used to do it at the bedside through the umbilical vein, and I can tell you that when Dr. Milton Paul designed the Rashkin embolectomy catheter, he put a bend on it so that it would go through the ductus venosus. So after you've done a balloon, then you can assess the size of the shunt. It's very helpful to do it this way, but it's much nicer and will make you happy when you hear the saturations rise from the 60s and the 70s into the 80s and the 90s. Makes you feel a lot better about the Rashkin. Steve, I'm going to talk a little bit about the operations for transposition. We talked about the Ductus Arteriosus before. Seem to have run on a little bit now. So the operations for transposition, the arterial switch seems to be the operation that's got the best results these days. I think there are very few people that are still doing the sending mustard as a primary relationship. This is from Frank Hanley's books. It sounded a reasonable way of doing it. You just switch the vessels and cut off the coronaries and transplant them so that the ventricles receive oxygenated blood. This is a picture from the late Barrett boys and not McGoon. Remember the surgeon from Birmingham? John Kirkland's book. And the excellent drawings show the heart in surgical position, excision of the aorta and the pulmonary arteries, pulling through the pulmonary arteries, switching the aorta, taking the buttons off, switching the aorta, putting the buttons in the suture where you connect the aorta, and then connecting the pulmonary artery distal stump to the old neo-aorta. So when we look at this procedure, we want to look at ventricular function, and this is easy in the operating room. The surgeons always know whether the perfusion is good. It's very easy for us to do because when you put a patient on cardiopulmonary bypass with cardioplegia, even so that you put them on, there's a tremendous accumulation of metabolic products, even though the heart is cold, and there's tremendous vasodilatation, so you can see coronary flow running within the myocardium very clearly. We look at left ventricular function, which is easy to assess, the anastomoses, the proximal anastomosis to the aortic root, the arch, the right ventricular outflow tract, subpulmonary area, the pulmonary valve area, and the main pulmonary artery, old pulmonary artery to coronary anastomosis, and residual lesions. We look at effusions and diaphragmatic palsies. So here, as we run this picture, looks like there's really nothing wrong with this, but as you can see, when you add the color flow sample, there's mitral regurgitation and a small muscular ventricular septal defect, which electively was not fixed. We look at the buttons. Here's a button. You can see the button of the coronary artery coming off here, and the now aorta coming from the left ventricle. We look at the button here. This is the right coronary artery button. Pulmonary artery is now in front of the aorta. You see the left and right atriums lying behind. This is an unusual operation that used to be done if the coronary artery is not switchable because of intramural course or something. The old sort of modified Takeuchi approach for anomalous coronary arteries with a hood, usually of one of the pulmonary arteries, pulmonary valve leaflets, is placed over the coronary artery and directed to the neo-aorta. Of course, it destroys the pulmonary artery. There's often pulmonary stenosis and pulmonary insufficiency that develops. And I think the end result of this operation is exactly what you see here, with the patient having landed on the autopsy table. And certainly we are able to see this with the ultrasound in life as well. Here's the hood of the pulmonary artery. The coronary artery is draining into this section. Here's the anastomosis. Here's the area where the surgeon has left the aorta open so that the aorta perfuses into this coronary vessel. We want to look at the distal, I beg your pardon, the anastomosis between the neo-aortic valve and the old aorta. And I think you can see that very nicely. See it lying between the pulmonary arteries, which are now being pulled forward over the aorta, and we'll get a look at that in a few moments. We look at the aortic arch. Make sure that there's no obstruction to right ventricular outflow tract. This patient has a wee bit of pulmonary insufficiency, not much, as you can see here from the MQ, aortic insufficiency from the MQ display. Nice flow signal. Now, the one feature of a arterial switch is it's the only time where the pulmonary branches lie in front of the aorta. This is a high parasternal or suprasternal notch. I say it's parasternal because in the suprasternal notch the aorta runs in this direction. When the aorta runs in this direction, it's high parasternal or a transmanubrial view. Ascending aorta, vessels to the head and neck, transversic aorta and descending aorta. And here in front of them lies the pulmonary anastomosis. And if you scan a little bit one direction and the other, this is the innominate vein. There's the pulmonary anastomosis there. So pulmonary anastomosis, innominate vein, both running in front of the aorta. Now we're looking at the pulmonary arteries as they come up over the front of the pulmonary artery, and you see the whole confluence. It's kind of small. Frequently the surgeons pull on the vessels. They're elastic, so as they stretch them, they make them a little on the small side. And we tilt the probe a little bit to the left or the right. In this case, to the left, we see the left ventricular the right ventricular outflow tract, the pulmonary valve, and the left pulmonary artery as it's running off this anastomosis. There's a small amount of pulmonary insufficiency, and although the pulmonary signal is only 1 meter per second, there's no pulmonary stenosis. We can come up a little higher, and now we see the aorta, and we see the bifurcation of the pulmonary arteries from the main pulmonary artery here, going to the left and to the right, in front of the aorta. And angiographically, that's what it looks like. You see, it looks like there's a little kink at the point where the anastomosis, but very good sized pulmonary arteries over here. And here is a later picture of a patient like this. Here is the ascending aortic transverse junction, and here are the pulmonary arteries. The pulmonary arteries are rising here, and the two branches are draped like a set of trousers over, straddling a horse's body over the aorta, running to the right and the left, and we can evaluate the flow velocity in these various structures as well. And particularly in this case, the caliber looks excellent without any evidence of peripheral pulmonary narrowing. We can trace the pulmonary arteries out to the left lung. Here we've scanned from the subcostal view and the oblique view so that we can get into the pulmonary arteries, and you see the left upper and left lower pulmonary artery running into the left lung without any acceleration or change of velocity in the branch pulmonary arteries. Now, the atrial switch procedure isn't done anymore. For me, the easiest thing to understand is the Mustard operation. Bill Mustard worked in Toronto, where Mark Friedberg is now working, and it's a very simple operation. Actually, the operation's intent is to take superior vena cava and inferior vena cava blood, make an anastomosis, and direct it to the mitral valve the pulmonary veins then scoot upwards and over this baffle and into the tricuspid valve. So you get a sort of a double C appearance. Now, the Senning operation has exactly the same intent, but it's done differently. It's done because Senning felt that the mustard procedure, which is done with pericardium, or before that with Dacron, tended to contract and cause obstruction to the pulmonary veins, used this approach involving the atrial septum, excising the atrial septum and moving it to cover the pulmonary veins, and then make an anastomosis in the back part of the vessel here, close the anastomosis so the pulmonary veins were left on that side. And it's a little bit more complicated here, the pulmonary veins running behind there. He then took the atrium and sewed it over here so that it's all tissue, native tissue, connecting the superior vena cava to the inferior vena cava by sewing in this direction. And then taking another patch and placing it so that the pulmonary veins scoot over this into the tricuspid orifice, which is seen over here. And essentially, it's the same technique but involving a different set of vessels. Now, the interesting thing from our point of view is that echocardiographically, they look very similar. It's not easy to tell one from the other. So here's a classical Senning mustard, should we say. I know these are mainly Sennings because we don't have very many mustards still left in our patient population. We stopped doing the classical mustard operation in the late 1970s. So here's where the pulmonary veins are. And the pulmonary veins scoot over that little area there called the isthmus, where you can get obstruction to blood flow, in fact, and then comes over and drains into the tricuspid valve. So pulmonary veins drain to tricuspid valve, which then, because there's no arterial switch, drains into the aorta, and the superior and inferior vena cava drain through this baffle into the mitral valve, which then drains into the pulmonary artery. So a negative procedure. And there are all the labels, which I'm sure you'll enjoy reading. Now, after the Senning operation, sometimes with tricuspid regurgitation, progressive right atrial hypertension, this area becomes rather large, and then the systemic chamber can become rather small. So you can get flow disturbances in this chamber, which also cause flutter on the mitral valve, but they don't really amount to a whole lot of information. The big problem with this operation, as in later patients, as you can see here in a patient who's clearly of adult size, is that as the right ventricle dilates, the amount of tricuspid regurgitation increases, and more tricuspid regurgitation gets more right atrial and right ventricular enlargement, which further gives rise to tricuspid regurgitation, and long-term tricuspid regurgitation in a systemic ventricle like this leads to myocardial failure. And certainly in their 20s and 30s and 40s, many of the Sennings and mustards are failing because the right ventricle is failing, and much of that is actually related to tricuspid regurgitation. Also some VSDs. The other thing that can happen is if there isn't a whole lot of tricuspid regurgitation and the heart develops, that you can get contraction in this mid-portion of the baffle. I haven't seen one for quite a while, hence the still frame picture from my textbook in 1990. And you can see here a gradient developing by color flow as the blood comes from the pulmonary veins and has to scoot across this narrow isthmus of the pulmonary venous baffle, and is causing a continuous flow at about 25-30 millimeters of mercury all the time. And this patient actually underwent a successful ballooning of this with remarkably good relief of the matter. And I'm going to hold this for the Rastelli procedure because generally this procedure is really confined to an old-fashioned procedure done in patients with double outlet right ventricle. Now, one of the things that can happen is when you put the baffle in the atrium, the one problem is if you put the baffle too close to the pulmonary veins, well, if you take the atrial septum out entirely, and you then have to put in a baffle between the cavae and the pulmonary veins, there's a very small space. And if you err too much to put them close to the pulmonary veins, you can get pulmonary venous obstruction, which is a bad, bad disease. If you put them too close to the superior and inferior vena cava, you can get systemic venous obstruction, which is not a good disease, but it's not quite as bad as pulmonary venous obstruction. And so the surgeons that I worked with tended to do this. And here's a patient with SVC obstruction, and you can see when there's obstruction to the superior vena cava, you can see a jet coming into the atrium. And then, of course, there's a pop-off valve called the azygos vein, and the azygos vein blood is coming in red down towards the diaphragm and decompressing this structure. So that's an interesting sign of obstruction of the superior vena cava. And there are many techniques for recognizing this. The color is probably the easiest. This is another text from my 1978 textbook on echocardiography. And what we did in those days was we used saline contrast because we didn't have any color flow. It's still a very, very good test. So you inject some saline microcavitations in the heart, and in the normal circumstance it goes down the superior vena cava, some of it will reflux into the inferior vena cava and then through the mitral valve. But if there's some obstruction, then what happens is the blood goes down the azygos vein. The azygos vein collects into lumbar collaterals, and then the blood comes up from below. Now, if you've got partial flow here and partial flow here, you can see the flow coming in the superior and inferior cava limb of the baffle very easily. Under this circumstance, SVC flow is usually, pressure is under 4 millimeters of mercury. Here, it's between 4 and 8, and if you get total obstruction, the pressure is usually above 8 millimeters of mercury. So if you do this bubblegram and there's total obstruction, then all of the blood flow goes down from below. Let me just give you one hint here. You can imagine how slow blood flow is when there's obstruction. It's got to go down the lumbar vessels, and then it gets back into the inferior vena cava, and then it comes up. So if it's flowing at that rate, and you have to watch this going, you can't look for the bubbles in the inferior vena cava immediately. You have to have a lot of patience before you record them, otherwise you'll miss them. So here's an example of what happens when there's obstruction. This is SVC injection of saline-containing contrast material, and as you see at the beginning of this, there's nothing coming from above. All of the blood flow is coming up the inferior vena cava from below. So if you've injected it from here, you've got almost total obstruction. Very simple and easy test, easy way to do things. So that's all I have to say on transposition at this time. Steve. Yes.
In a neonate, with the classical transposition, with the foraminal with the ventricular septal defect and Ductus. At the atria, I have blood from left to right. No, from left to right. Okay.
If you have a ductus, yeah.
Okay. And it's the ventricular septal defect, right from left.
Both ways. Yeah.
Well, it depends on how old the baby is. Pretty
Pretty
quickly.
quickly. You also may have bidirectional flow.
Hang on a minute. So what's your question?
No,
You want to know?
yes.
Yeah. Well, the most important thing is the atrial left to right shunt at atrial level. Okay. I mean, that is not like a ductus. You give a prostaglandin to a baby, you open the duct, okay? You tend to close the atrial septum. The patient is still maybe needs a rationing. If the atrial septum is incompetent, as it frequently is, then you get a left to right shunt at atrial level. You're getting pulmonary venous blood to the brain. That's the most important thing. If you have a big VSD, you're going to get pulmonary venous blood to the atrium regardless. Although there's a bidirectional shunt, there's still a bidirectional shunt even if it's at atrial level, it has to be. But the most important thing is, pardon?
Not if there's a ductus. If there's a big ductus, and the ductus will go from aorta to PA, and the atrial will go from LA to RA.
LA to RA, yes, exactly. So the ductus The important thing about the ductus is it increases the volume, but if
Correct.
it increases the volume and you have a competent foramen, you can actually make the patient worse.
You can put them in pulmonary edema very quickly.
And you can make them blue as stink because, and
pulmonary
that's, I tell you, I found even in my own hospital, I come into the hospital and they tell me, oh, the saturation is
Seen
fine. That's fine in this patient, and they're taking it in the leg. Okay? So the leg is seeing what's going on at the different levels, and that has got no reflection of what's happening important, which is to the baby's brain and the baby's heart. So you must make sure when you do that you're looking at upper limb to see what the saturation is. That's really the most important thing in transposition. But the most important thing is the atrial left to right shape. That's, and of course if you've got a big VSD, the atrium is not that important. Okay.
Sorry,
Yes, yes.
could you explain why the destinal transposition great artery with the Ventricular defect and for coronary stenosis, several surgeons suggest any kind of procedure instead of the switch, the arterial switch operation?
Well, you can't, once you have a problem with the great arteries, if you have severe pulmonary stenosis, you actually, if you just do a switch, you're going to have severe aortic stenosis. So that becomes worse, and for that you have to do something like an Apical or an Aureli, what we used to call it already, half of a Nord, half of a steady operation. Because once the pulmonary valve is damaged, you can't really use that. Yeah, so I think that's why the surgeons are suggesting that. Okay, once there's pulmonary stenosis, you've got trouble for an arterial switch.
If it's real anatomic pulmonary stenosis, yeah, that's right. Because you're putting the pulmonary valve in the systemic position, so you're trading pulmonary stenosis for aortic stenosis, which is not a good trade.
And also, I mean, even so, if just a bicuspid pulmonary valve, they will do the switch anyway.
Yeah, yeah.
Even though that they're problems.
Yeah, yeah. And I think that's probably
in most
reasonable.
circumstances, but I guess that.
But not with, particularly with posterior deviation
Right.
of the infundibular
So
septum. That's the one
as we
that's
said,
hard to fix.
If that is shown on his autopsy specimens, and I showed you, when the septum is deviated like that, there's often problems, and then you can't do the switch, simple switch. It's a very complicated operation.
So we thought we would just show one or two examples of the other type of transposition, which is congenitally physiologically corrected transposition, or transposition where the ventricles are inverted and the great arteries are in L position. And we'll show you an example or two of that, and then I think Mark is going to talk about function in that condition, because that's a real problem, because the right ventricle is the systemic ventricle. So here we're looking from the front. Here's the aorta over here, anterior and leftward. And here's the pulmonary artery here, posterior and rightward. So just the opposite, more or less, of what we saw in the other type of transposition. Now we're looking in the right atrium. Here's the fossa with septum primum, septum secundum, coronary sinus ostium. Here's superior vena cava and the appendage with pectinate muscles. Now, when we go from this right atrium to a ventricle, we don't cross the tricuspid valve, we cross a mitral valve. Look, this is different from what we've seen before. Here you see a smooth septal surface. You can see there's one papillary muscle up here and another papillary muscle group here. These are free wall papillary muscles. There's no insertion onto the septum. You can see the medial leaflet here separate from the septum. Here's the outflow tract in this case to the pulmonary artery from the left ventricle, so it is transposed. And here on the right side, here we see the tricuspid valve. Here's the septal leaflet. Here's the anterior leaflet, and here the aorta is way back up here in an outlet chamber, a big infundibulum up here above the right ventricle. And notice also that this tricuspid valve is very abnormal. Notice that the septal leaflet here is adherent to the interventricular septum. This is a form of Epstein's abnormality of the tricuspid valve, which is relatively frequent in patients with corrected transposition of the great arteries. Notice that the delamination doesn't occur until we get almost to the apex. All of this, the annulus is back here, so all of this is bound down, and this is part of the atrialized ventricle. Here's the anterior leaflet. Here's the left atrium. You can see septum primum on the left atrial septal surface here. The fossa is pretty much intact. The coronary arteries are more or less opposite of what we would usually see. Here's the right-sided coronary, which gives rise to a circumflex coronary back here. There's a marginal branch here, and then an anterior descending, which comes down the interventricular groove here. There's also a conus coronary, which arises from this, which supplies the big aortic, subaortic infundibulum up here, which quite commonly can arise from either coronary, but frequently in corrected transposition, it arises from the right-sided, morphologically left coronary. And here we see the left-sided coronary, which looks more like a right. It just goes straight back into the left AV groove and goes around to the back wall of the heart. So the coronaries are more or less inverted, like the ventricles. The coronaries go more or less with the ventricles, although the patterning of the coronary arteries is not perfect. I'll show you one example with a ventricular septal defect, and then we'll move on and ask Mark to do the problem with function here. Maybe I will. I don't know why this is being so difficult. Maybe I won't show you one with the VST. Here's one with see if this one will play. I don't know why the other one won't. Yeah, this one's going to play. So here's an aorta, again anterior and to the left. The pulmonary artery is over here, posterior and to the right, and quite small, as you can see in this patient, because there's pulmonary stenosis. The valve is here. And here, if we look in this atrium, you see there's a large, multiply fenestrated septum primum, a large atrial septal defect here, with multiple openings into between the left and right atrium. Here's the coronary sinus down here, and this is part of the eustachian ridge right here. You can see there's a bit of a Chiari network in this right atrium. And again, we go across a mitral valve here, but notice this is a very abnormal mitral valve. There's a cleft in this mitral valve right here in the middle. This is the superior part and the inferior part. And this cleft actually had attachments at one point onto the septum. I think they were disrupted post-mortem, but the valve went like this, and so it attached onto the septum there. And since the outflow tract of the left ventricle is between this medial leaflet and the septum, you can see there was quite significant subpulmonary obstruction in this case. And you can see how small the pulmonary artery is. There's also a ventricular septal defect here. There's the pulmonary outflow up here. And if we look in the left side, the right ventricle, here's the left atrium, you can see this septum primum that's multiply fenestrated here, so there are big atrial communication in this case. From the left atrium, we cross the there's the appendage up there, yeah, the atrial appendage. And then we cross the tricuspid valve in this case to get into the morphologically right ventricle. Here, there's no Epstein malformation of the tricuspid valve. You can see this is the septal leaflet. It attaches normally to the septum. There's a large ventricular septal defect here. Here's the septal band up here. And the inferior and superior ramus of septal band. And in fact, this is the aortic valve up here. So the systemic ventricle in these cases is the morphologically right ventricle, and that seems to be a significant part of the problem that these patients have with developing right ventricular failure. It's quite prevalent. Most patients, by the time they're in their 5th or 6th decade, have evidence of ventricular dysfunction and failure.
So, thanks, Steve, for setting me out to talk about functional problems. Everyone okay? See a smile? Okay, so I'm actually going to talk, start off by talking about complete transposition or simple transposition, the type we talked about before, where the great arteries are just switched around. And over here, there also, you would think, be potential problems with function, because sometimes there are coronary anomalies, as will be discussed at the coronary session, that may lead to ischemia. You can have valvular regurgitation with increased preload. There's sometimes residual lesions to further increase that preload. You can get either neopulmonary or neo-aortic narrowing, as was shown in some of the pictures, which will increase your afterload. You can have regurgitation of the neo-aortic valve, which is increasingly being recognized as a long-term and progressive problem that's going to further increase your preload. And I'll talk about aortic insufficiency when we talk about bicuspid aortic valves tomorrow or the next day. And then, as alluded to, if you are going to do an atrial switch procedure, you're leaving the right ventricle as the systemic ventricle, which leads to problems. So here is complete transposition, that you've seen the anatomy and the echo. But despite all those potential problems, I want to say that if you look at how patients are doing after an arterial switch operation, they're doing very well. So it doesn't seem like those problems are very prevalent or very important. And here's your risk for instantaneous death or bad problems, and it goes way down after the first year. But and you can see just a minority in terms of function. 1.7% had some regional abnormalities. A small percentage had a decreased shortening fraction, and 13 of this series, I'm sorry, I didn't write how much the series was, but 13 patients required a pacemaker, which can also lead to functional problems. But nonetheless, we should remember that there are those problems I pointed out potentially. Here's pulmonary stenosis in a significant amount. Here's the pacemaker, residual shunts, coarctation of the aorta, afterload in terms of left ventricular outflow tract narrowing, mitral insufficiency, and coronary stenosis. So still there are problems that potentially can impact function. And in fact, this is a 17-year-old who I read the echo on, who originally or still has a single coronary artery and had the operation that Norman alluded to, the Takeuchi procedure, where they tunneled the anomalous coronary, reconstructed through the pulmonary artery. And the function wasn't quite normal. He originally did have coronary artery obstruction. And if you look at the tissue Doppler, it's not too bad, but you do have decreased velocities here on the septum. So normal should, at this age, should be above 10 and certainly above 8, and they reduced here at around 5. And the diastolic velocities were mildly reduced as well, but not too bad, and overall saw a normal Doppler, tissue Doppler pattern. Now, if you look at transposition of the great arteries and you look at strains of the myocardial deformation, actually this is quite interesting. This works intermittently, so if I try and it doesn't show, it's not because I'm crazy, but it's not working. So if you look over here, you can see that there is a mild reduction in strain across the different ventricular segments. It's a mild reduction. If you do statistics on a large enough population, it is significant. But what we don't know is what it means. So does this decrease in the way the muscle contracts long term? Is that a problem or not? Based on that first slide I showed you, it's not going to be too much of a problem, but it's certainly interesting that you'd have this decrease almost across the board. The other thing that was decreased was the LV rotation or twist. So I told you that the ventricle ejects not only by shortening and not only by contracting in the radial direction, but also by twisting, just like you twist water out of a wet towel. And so that's also decreased in these patients. Why? I'm not sure. Is it coronary issues? We know that adults with ischemia have decreased torsion, or is it other issues? I'm not sure what the etiology. Now, some people have also pointed out that there is right ventricular abnormalities after arterial switch operation, and in fact have shown diastolic dysfunction of the ventricle. This was MRI data, where you can see that this is an E wave and an A wave, so your inflow into the right ventricle, early diastolic inflow, late diastolic inflow. This here is the controls, and this here are the patients. And you can see that they have delayed relaxation. Their filling is slow, and you get that decreased slope of filling. And in this paper, it was related to stenosis of the neopulmonary artery. So even mild stenosis on those surgical anastomoses over time can cause an increase in your right ventricular mass. And they had a smaller cross-sectional area of the pulmonary artery, and this caused some right ventricular diastolic abnormalities. Acutely after operation, after the arterial switch operation, I've shown the same paper in several talks, but Michael Chung looked at the transposition patients as well. And what you see here, here's the normal force-frequency relationship. So you pace the patients at increasing heart rates, you'd expect an increase in their contractility. But if you look after an arterial switch operation, they have a flat FFR response. They need support, they need the ICU, they need inotropes. So that is in terms of transposition of the great arteries, meaning there can be abnormalities. We see subtle abnormalities over the long term. It hasn't impacted survival, at least in about 20 to 30 year follow-up. But remember that there can be late problems. Now, the systemic right ventricle, I think, is a very interesting subject, and mainly, as Norman pointed out, we don't do atrial switch procedures very often, but there's a whole population of adults that underwent atrial switch procedures 20 plus years ago and are now in their adulthood. But I think actually for neonatologists it's a very relevant problem, because the right ventricle faces high afterload in the neonates as well, and perhaps there are lessons that can be learnt and when function stays good and not. So don't switch off because these are patients that are now 30 or 40 years old. But actually the RV can be systemic in two situations. Either, as Dr. Sanders showed, when you have congenitally corrected transposition of the great arteries and you leave the right ventricle as the systemic ventricle, or after atrial switch procedure for so-called detransposition of the great arteries. And as opposed to the regular transposition that I showed you, here patients, as pointed out before, are not doing well. Decline in ventricular function and clinical condition, long term. And this is after atrial switch procedures. The Mustard repair, it should have been with a capital N. This is a high impact journal, and Mustard is a name as far as I understand it. Anyway, this is not an English lesson. So they're doing poorly, and you can see the New York Heart Association class over there at baseline in 1990 and then in 2001. And you can see that there's a much higher proportion that are now in class 3 or class 4. So clinically, they're not doing well. And they're not doing well because this is their right ventricular systemic function. It goes from good or mildly reduced to moderate and poor. That's the problem. And it's related to TR, and it's related to the actual ventricular function itself. And they don't do well also from an exercise capacity point of view. And so this is a huge problem. Now, I told you that deformation will correlate. In essence, it's like a regional ejection fraction. And if you sum up the strain in the different parts of the ventricle, you're going to get an approximation of an ejection fraction. So indeed, if you look at the RV lateral wall strain in this paper, it correlated quite nicely with right ventricular ejection fraction by MRI. That's, I think, useful for follow-up of patients, because if you don't want to do an MRI every single time, if you don't have the facilities or it's expensive, this might be a nice way to follow patients over time. Now, again, Benedict Askins looked at strain and strain rate after an atrial switch procedure in TGA, and this is, again, simple TGA, it's not congenitally corrected, but nonetheless it's a systemic RV. And what you can see here versus either the subpulmonary normal RV in control patients or the systemic LV in control patients, you can see that function is reduced when you look at systolic strain or strain rate, and in this instance also velocities. So you can see that anywhere you look, the base, the midwall, and the apex of the RV, they have lower deformation. It doesn't contract as well. And it doesn't contract as well. You might say, well, it's because it's the blood pressure, but it doesn't contract as well even if you look at an RV, not only at an LV. And again, the correlation shown here between ejection fraction and strain rate. Now, if you look at this panel over here, this is what I was saying about velocities. This group used this data to show why strain may be better than just velocities. Because if you look over here, the velocities in the setting and the normals were almost the same, and strain rate were reduced. So they claimed that this was a better measure of looking at it. Now, individuals that have a systemic right ventricle and are even asymptomatic also have reduction in the deformation. And perhaps this is useful then to look early at patients before they become symptomatic and pick up on this much earlier when maybe you can do something about it in terms of what's causing them. And so you can see this paper's asymptomatic individuals. It's a combined effort across the Atlantic from Nijmegen in Holland and Rochester, Minnesota. And you can see over here whatever index of right ventricular function you choose to look at. Over here is the myocardial performance index. Here's strain rate. There is displacement of tissue, so motion of tissue, and there's strain. Wherever you look, the congenitally corrected transposition of the great artery function was worse compared to the normal control. So that means a higher myocardial performance index. It means lower strain. Strain rate, if you look, longitudinal strain and strain rate, because it's a shortening of the tissue, the sign is negative. So it's less negative, meaning worse deformation, meaning it doesn't shorten as much. The same thing for strain, and then it displaces less. So this may be a good way to pick up on patients when they're still asymptomatic. Another way that's been done is I showed you with isovolemic acceleration. So if you look at contractility, which is measured, and I don't want to go into this whole thing of pressure volume loops and the end systolic elastance, but all I'm saying is if you take a family of pressure volume loops and you look at end systole, and you look at it over a few pressure volume loops, the slope of that relationship between pressure and volume in your ventricle is a good measure of contractility. And that's all I really want to say about that right now. If you give dobutamine to patients, and that's what you do in the NICU the whole time, you can increase that slope, meaning increase the contractility. And we can get at that by tissue Doppler as well, by measuring the isovolemic acceleration, which I talked about in the first instance. So here's dobutamine, here's your IVA spike, and you can increase the slope of the IVA over there with dobutamine. So if you take this and you try it on patients who have a systemic right ventricle, and this is work from Michael Vogel, who's in Munich, and Andrew Reddington, who's my boss, if you look at that, you can see that, again, the change in IVA relates to the change in end systolic elastance, those pressure volume loops. So you can use this to test that. And you can see that both velocities and IVA are reduced in patients, and they do increase with dobutamine, but probably not as much as control patients. It's very interesting that these patients don't have only systolic problems, but it may be that the problem is in filling of the heart in diastole. So this is a paper out of, I think it's Austria. And if you take these patients and you exercise them, I told you that many of these abnormalities will only manifest when you really need that functional reserve of the heart when you're exercising them. And you exercise the patients. Well, here are controls, and this is systolic strain of of the controls, and this is the diastolic velocity, and this is the systemic ventricle. Look at controls of the strain. During exercise, they'll increase their strain to increase the contractility to put out more cardiac output, whereas the patients with a systemic right ventricle are unable to do that, although they do it slightly. But the real problem is in diastole, and this is tissue velocities. Look here at controls. As you increase the workload, you increase them on the bicycle, their diastolic velocities increase. They fill rapidly and they fill well. But the systemic right ventricle of those patients is unable to fill as well and is unable to increase their cardiac output. But what's really important, and remember this in cardiology and function, it's never a problem of one ventricle alone. There's always the other ventricle as well. And if you look at the subpulmonary ventricle, we always say that the right ventricle was designed or made or should function over long term under low pressures. Sorry? Evolved. I didn't want to be, too charged and get into trouble. But evolved as to operate under low pressures. So you should have said to me, well, the left ventricle that was designed to function under high pressures should function very well as a subpulmonary ventricle over time. And this data suggests otherwise, because if you look at this at the subpulmonary ventricle in congenitally corrected transposition, you'll see that compared to controls, the left ventricle is also dysfunctional. Well, I brought myself all the way over here, but I'm changing slides, so I have to go all the way back, and that will keep me awake. And so we have problems. So how does the right ventricle handle this? Well, if you look at pulmonary hypertensive ventricles, and I thank Andrew Reddington for the slide, and this is the same pressure-volume loops, right? So it's the relationship between volume and pressure. This is a normal left ventricular pressure-volume loop. It's a square-shaped ventricle. The left ventricle, as a systemic pump, is a square pump, okay? This here is filling, isovolemic contraction, so pressure goes up but volume doesn't change. Ejection, where volume goes down, pressure stays high. Isovolemic relaxation, so the pressure drops but the volume doesn't change, and we go around again. The right ventricle, the normal right ventricle, has this shape. It's almost a trapezoid or triangular shape. So here's its filling, here's isovolemic contraction, ejection, and there's hardly any isovolemic relaxation. When you place the RV in chronic pulmonary hypertension, it does that. When it adapts, it goes to a left ventricular form. And if you talked about that elastance, that slope of the end systolic pressure-volume relationship, it goes from that to that. So it adapts to its new condition. And one of the reasons that it may be able to do that, and one of the reasons that some patients fail and some don't, is because if you look at strain patterns of the systemic right ventricle, they become much more like the regular, normal left ventricle. So here is a normal longitudinal strain on a normal RV. And you can see in the systemic RV, they have decreased longitudinal strain, and much more circumferential strain. So the systemic right ventricle adapts a more left ventricular pattern of contraction. What it doesn't do, though, it doesn't adapt to torsional rotation. It's unable to do that, and that's probably because of the fiber orientation in the right ventricle. So it may be that patients that are able to do well over time, or neonates that are able to handle pulmonary hypertension over time, it may be that the ventricles adapt better. I think, so I'm just going to show 2 or 3 examples with strain. Here's a patient with dextrocardia, congenitally corrected transposition of the great arteries, and you can see that left ventricular function, even by eyeballing it, is reduced. You can use what's called vector velocity images. You remember I showed you tracking the endocardium and those speckles over time to show the deformation. This doesn't loop, but you can see eyeballing it that it looks abnormal. Instead of all coming in, the septum goes the other way. And if you look at circumferential strain on the septum, this is the posterior wall over here in blue. you can see a good circumferential strain. It's reduced, but it's a normal pattern. You can see that the septum doesn't have much circumferential strain at all. And you can try this on the longitudinal strain, and here you can see the longitudinal strain is better, but it's still at very low strain. And here's one with good RV function. This is a congenitally corrected transposition of the great arteries. Here's the displacement of the tricuspid valve. If you look at this systemic RV, again, you see decreased longitudinal strain in orange on the septum and better strain in the lateral wall, although still reduced. So I'm going to end over there with those examples of how to assess this.